And good evening, everyone. And my name is Dr. Fahim Shakur. And along with my co-host, Dr. Mehran Javed, welcome to another episode of Med Talks on Pendle Radio 103.1 FM. The numbers, as per the usual housekeeping for tonight's show, is 01282 723 455. If you've got a question, today's topic is on pharmacy, a full Q&A along this broad subject for the next hour. We also have a WhatsApp number, 075 22723 455. I repeat, 075 22723 455. Over to my co-host Mehran to introduce our lovely guests tonight.
Cool, thank you, Fahim. And just for listeners, be mindful that it's also being broadcasted live on YouTube as well as Facebook. So please do search for Med Talks. That's Med Talks with an X. So interact, ask questions. We'll try and put it forward to our guests. So I'll start with Atif. So Atif Saddiq is a portfolio pharmacist with a keen interest in general practice, academia, and early careers. He's got lots of hats on, but he's also the co-founder and director of Primary Healthcare Development, which is an independent training company, along with also being the inaugural chair for the Royal Pharmaceutical Society's Early Careers Pharmacist Advisory Group. So I understand you qualified in 2014. Is that correct, Atif?
Yes, that's correct. Good evening, everybody. Pleasure to be on this show today. But yes, I did qualify in 2014. Thank you for that very lovely introduction there, Fahim. And Dr. MJ, you've got your name down as Dr. MJ on the screen, so I'm going to constantly forget your name. I'm really sorry.
It's Mehran, but yeah, I'm
Mehran.
trying to publicize my Twitter account. But
okay.
So thanks for that, Atif. Great to have you on board. And the next guest is Colin Ferns, who graduated from Liverpool John Moores University as a pharmacist a few years before 2014. And you've also worked. You've also worked with prison, developed special interest in mental health as well as drug and alcohol dependency, and you joined Delphi Medical about 7 years ago with a keen interest of being part of a company that has very strong values and vision for the future. So great to have you on board, Colin.
Yeah, good evening, Mehran. Good evening, Fahim. Yeah, it was 2000 that I qualified in. So yeah, a couple of years before. So I've been community, prison pharmacy, and in substance misuse as well. So I work for Delphi Medical, and we work in community and Blackpool and lots of areas of substance misuse. So yeah, it's a good area to be in. It's interesting.
Yeah. So it'd be very important to have your take on, especially given the current circumstances, Colin. But I'm going to start with you, Atif. How did you get into pharmacy?
Okay, yeah. No, how did I get into pharmacy? So, with myself, then I was brought up in a family whereby none of my parents actually had been to university. So, university wasn't a thing within the family in itself, but ever since, from a young age, my mum was very insistent that all four of her sons would do something at a university level, so higher education. So having that in mind, I knew that I did and want to, and I guess need to go to university. But at the same time, I was one of those kids who'd always, you get one kid in the family that's always getting hurt in one way or another. I'd either fall off a bike, I'd get hit by a car or something like this, but I'd end up in the hospital quite often. And I guess just being around, nurses, doctors, pharmacists within a hospital setting, I knew I wanted to do something healthcare related. And then when it did come to my A-levels, I was introduced to pharmacy by one of the school teachers as a potential career option. So it's something that I did explore at that time. And for me, things really clicked when it came to things like, solving problems with medicines and looking at things like interactions, etc. And for that reason, I did go ahead and apply for pharmacy. So that was my way in, I guess. And then, yes, I did learn a lot whilst I was on my undergraduate course, followed by, extensive experience within the profession. But yeah, I guess it'll be quite interesting to hear how Colin got into pharmacy himself as well.
Over to you, Colin.
Well, yeah, as I say, I went to Liverpool John Moores. I originally I wanted to be a dentist, and as things would happen, I ended up being a pharmacist, not being a dentist, and it was probably one of the best things that ever happened to me, and it just gave me such a broad range of job to do. And I went to the community aspects. I went into boots management, and I just really missed the clinical aspect and the actual patient content. So I ended up locuming in prison pharmacy, and unfortunately I went to prison supposedly for 6 months, and I was there for 5 years. So it's quite a difficult place to get out of, but I loved every minute. And it gave me my specialism in substance misuse. I did my prescribing there, and then it also allowed me to develop into leaving and joining Delphi, be involved in some.
Just checking, Colin. As in, you went there to work, right?
Yeah.
Right.
Yeah.
I'm just double checking.
Yeah. So yeah, it's always a bit of an icebreaker, especially when you're out having a dinner and someone hears you say, "Oh, my son's in prison." Oh, my mum's she does like the conversation, but yeah, I mean, I absolutely loved it. It's like a mini hospital. You get very clinical, and you get such good access with people that are very stigmatized. And one of the main things about working in prison is that people are getting punished in prison. You choose to work in a prison, therefore you're there to help their healthcare needs. I'm not there to judge them from whatever they've done. Why they've done it. I'm there to help them with their addiction and actually help them initially on how to manage their medication and actually work as a pharmacy inside the prison. And then we developed further into my prescribing role, and that just got more and more exciting, and the contact I have with our patients.
Excellent. Atif, obviously, we want to be topical, and with the A-level results having come out and then GCSE results imminent, can you give some tips for people who are thinking about their future career plans as to why they should perhaps go into pharmacy, or the other alternative route is pharmacology? Can you tell a little bit about the difference, and really what should they be aiming for perhaps when they go to college, and what should they be doing so they can actually get onto this program?
Yeah, no, definitely. I guess, like you say, at this moment in time, it is very a timely topic, very topical. I guess with the recent results day and the current clearing season, I'm not going to necessarily dive into the realms of what's going on in terms of the recent U-turn with results, etc., etc. A bit too controversial for a Tuesday night, I'm guessing. So, as you are aware, I do work at the University of Bradford as a lecturer in primary care pharmacy practice. So understandably, I am a little more intertwined with what their requirements are in terms of entry for the pharmacy course. But generally speaking, requirements for other pharmacy schools are very similar. And usually, I guess, to get into pharmacy school, particularly with the University of Bradford, because that's where I work, applicants usually require 5+ GCSEs, including grade 4 and above in maths, English, and 2 sciences. So, you have that background with regards to GCSEs. And then with regards to A levels, if we were looking at UCAS points, it's normally 128 points, so 1A and 2Bs. And it tends to be in the areas of, chemistry or biology plus another science. And then, you can have a mix and match of different A levels. There are other ways to get into pharmacy. So it's not just your routine A levels, you can go through the BTEC route. So applicants who have been successful in a BTEC extended diploma in applied science, both the newer and the old versions are also eligible, based on what grades they achieve for that. And if students do hold any other qualifications and are not too sure as to how these would count towards their application, most of the university admissions teams up and down in the country are very keen to help. So I would encourage any listeners who are students that are looking to apply to get online or get onto the phone and contact the universities directly, because remember, year on year we do see a lot of people who are successful with the clearing process. And I think obviously with the current ongoings, clearing will be even more popular this year. And I would like to also, I guess, take this opportunity to thank our academic colleagues who are currently working really hard and will be continuing to do so to help with the clearing process in the coming weeks. So that's just, I guess, an overview of how you could get into pharmacy school specifically.
Okay. And in terms of, obviously, there are other professions within the pharmacy itself. Could you tell the listeners a little bit about, I think there's dispensers and technicians and some of the other roles, and perhaps in case they don't perhaps want to pursue pharmacy, are there other roles in the pharmacy setting they can do?
Yeah, certainly. I mean, the thing is, with pharmacy, it's quite a broad profession to go into. You have your local high street pharmacies, also known as community pharmacies. We have hospital pharmacies. We also have, academia. I work part-time with academia. And then you have things like prison pharmacy. The actual scope for what you can do as a pharmacist is quite wide, but then there are other members of staff that are within the pharmacy team in itself. So if we were looking at community pharmacy as an example, which I think most of your listeners will be, they'll be able to relate to that a lot more because they'll have seen their local community pharmacy. But in terms of the staff that are available within a community pharmacy team, usually it's your pharmacists, your pharmacy technicians. We also have pharmacy assistants as well. All of these members of staff together, form the team. And if we were talking specifically about pharmacy technicians, they are recognized as healthcare professionals, and like pharmacists, they are registered with the General Pharmaceutical Council for their license to practice. And technicians are, really skilled and essential members of the pharmacy team who, tend to prepare, dispense, supply, and issue a wide range of variety of medicines and advice to patients. So if anybody did want to register as a technician, as a pharmacy technician, they can quite easily, bypass the route of obviously studying at university. There tends to be accredited courses that they can enroll onto, and this is usually in addition to some work-based experience within a pharmacy setting. So I guess that would be, maybe a parallel to working within a pharmacy team if you've not gone down that conventional route.
And Colin, what does the private sector within where you work at the moment, what kind of opportunities does it offer those interested in pharmacy? And do you see that evolving given the current circumstances with how people interact, with how people get experience due to COVID?
Yeah, I mean, when I first started trying to go in the private sector for the prison, there was a very small handful of pharmacists that work in the prison, and it was quite difficult to start off with because there was primary care, lots of legislation, lots of rules, lots of guidance. There was secondary care, lots of guidance, lots of rules. But it's a hybrid. You sit in the middle. There's a lot of different models to do with the prison, especially when I left Boots to go into the prison. And you leave a place of a lot of structure with a lot of support, a lot of training, a lot of conversation around that type, from university to basically being on your own and having to be very confident with your laws, your regulations, and also the fact that at the end of it, it's the patient at the end. So it's making it safe and legal. So I had to go into things about getting home office licenses for controlled drugs, setting up accounts. We didn't fall under the same rules as community pharmacies or hospital. You speak to the inspector, and they weren't sure because it was a newish area. It's a lot better now. You're talking sort of 15 years on. So there's a lot more people involved. So there are a lot more checking technicians. It's a lot more like community. And there's still not many pharmacists like myself that work as a non-medical prescriber in addictions. And I'm hoping to develop that as much as I can by shows like this, so people can be be interested in prison, being a prescriber, getting into addictions. I mean, a few years ago, I went into John Moore's and I would speak to the students about prison, and it is extremely interesting. The stories you can tell, the fear factor just isn't there. The people inside the prison, the staff, the officers, even the prisoners, they're still people that you meet outside when you work into Boots or you work into the hospital. And one of the biggest things I learned very quickly was you speak with respect to people, you get respect back. No one will shout or attack you or have a go at you if you explain clearly that this is why you can't have your medication, or you've not took it properly, and or this is why we're stopping it. And most of those medications happened around potentially medication they were prescribed from a GP, whether that be pain medication, sleeping medication, things like pregabalin, gabapentin, that sort of thing, that are deemed quite abusable. They come into the prison, and because they are in such a closed environment, we're not questioning the diagnosis, but we can review it, and we can have a better care plan than you can in the community. So we can introduce physios, psychiatrists, specialist help, dietitians if it's weight loss, and you're working in a much bigger environment. It's good.
So you've actually led on to because we've already had questions coming in. So one of the listeners did ask, why is it so difficult to find a prescribing pharmacist?
So it's not difficult to find one who has done the qualification. It's probably more difficult to find one who's in practice. So when PCTs were that were in all pharmacies, and a lot of money was spent getting pharmacists into the role of being a prescriber. But then unfortunately, a bit of politics, I suppose, comes into it, because pharmacists have always been deemed the person in the shop. They give out the tablets, and that's what they do, and you're stuck in that place. And then the nurse prescribers would come through as well. And it does come down to a financial decision, I suppose, and people assume that a practice nurse they'll go to. It's harder for a pharmacist to get into that position just from historic reasons. It's getting a lot better, and if you get a good pharmacist attached to your practice, they are worth their weight in gold, because they can do audits, they understand the medication, they can look at how they use their medication, they can look at your dangerous prescribing, if you like, so your addiction medicines that need to be reviewed, so diazepam, opioids, pregabalins, all those medications that if they're not kept under review, they can be difficult for patients to come off. But yeah, it's historic, because nurse prescribers became before pharmacy prescribers. So there are a lot of us out there, but we tend to get put in other roles rather than sort of patient facing. But I'm sure Atif could give a more up to date on that regards to coming through the universities with the masters.
Yeah, I mean, me myself, I work as a independent prescribing pharmacist at a GP practice. And I've done my advanced practitioner qualification as well. So I do tend to see, acute cases on a day-to-day basis, really, when I am working in the general practice setting. Like Colin says, things like nurse prescribers, they've been around slightly longer than the pharmacist prescribers. And to be fair, I was having a conversation with one of my nurse prescribing colleagues at the practice that I work at. And, she mentioned that when she was a prescriber, I think she qualified maybe 10 to 15 years ago, there was still a little bit of the, I guess, taboo as to, patients would come in and say, why am I seeing a nurse? Can I not see a GP instead? And I feel as though, when I did start off my role within the practice that I work at, there was that resistance from patients about, not being able to see a GP and why am I seeing a pharmacist? But as time has progressed, the patients that I have been seeing regularly and those that I guess I might not have seen, but the word spread within the community is that, these pharmacist prescribers can actually do a really good job, especially when it comes to things like medication reviews, because we do get to spend more time with the patients, go in a little bit more detail about the medicine and pick up issues that, are a little bit more, I guess, closer to things like their, usage of medicines and providing workable solutions to fix any problems that they might come across. But in terms of the prescribing, for those of your listeners out there that are not aware, usually when a pharmacist undertakes his or her undergraduate degree, we tend to do a year's placement. And by the end of that, I guess 5 years, so it's 4 years undergrad, 1 year placement. By the end of those 5 years, we don't qualify automatically, or we don't register as prescribers automatically. This is something that we have to do. Usually right now the requirements say 2 years later. And when we do undertake this prescribing course, it tends to be under the supervision of another prescriber, another independent prescriber, and it tends to be a course accredited at a university throughout a semester. So we get lots of hands-on training and things like this. But yeah, I think like Colin was saying, things are improving. We are seeing a lot more prescribers out there. There's a national push to get more pharmacists as prescribers in all sectors, even in hospital as well. We're seeing a lot more pharmacist prescribers there who are able to make them changes, there and then, really.
And Atif, in terms of the role the pharmacist will have as autumn and winter approaches, in particular reference with vaccination uptake and doing blood pressures and dealing with minor complaints and so on, could you tell maybe the listeners and also the viewers who are watching a little bit about all the roles the pharmacist has and how they actually work as part of the actual team in helping to meet not just targets, but actually help with patients' complaints and actually their medical problems?
Yeah, no, certainly. I guess this then goes into the different sectors, really. But if I was predominantly to focus on primary care, because I am usually split mainly in general practice, but I do have input in the local high street pharmacies, the community pharmacies. There is a lot that the pharmacy teams will be doing over the winter period and are doing throughout the year, I guess. In terms of community pharmacies, then in England, obviously, we work under something called the Community Pharmacy Contractual Framework. And this is a contract that's negotiated through the Department of Health and Social Care, as well as NHS England and NHS Improvement. And they come together with a body called PSNC, so that's the Pharmaceutical Services Negotiating Committee. And through this contract, community pharmacies will offer essential services. So all pharmacies throughout the country will offer key essential services. And these include some of the well-known services such as safe, accurate and effective dispensing of medicines, as well as disposal of medicines. But in addition to this, it also includes things like self-care advice, public health. And if community pharmacies wish, they can provide a whole range of other advanced, locally commissioned and private services. So this would include things like, the flu jab service, which if you are a patient who is deemed to be vulnerable and you fall into the national category, then you can get your flu jab for free at your local community pharmacy. I guess it does save time, appointment time, because pharmacies on the whole tend to be a lot more accessible. Things like emergency contraception, smoking cessation, minor ailment services as well. So there's quite a lot that can be offered by community pharmacies per se. And then if your GP practice is lucky enough to employ a pharmacist, then the pharmacists themselves can do some of the more medication reviews with yourselves as patients, and can also focus on putting, like Colin was mentioning before, putting safeguards in place to reduce the chances of medication errors. I do this usually on a regular basis, whereby if you have got high risk drugs like drugs that might be used for rheumatoid arthritis, we tend to put proactive measures in place so that there's a reduced chance of an error being made when anybody is prescribing, I guess.
Okay. And Atif, just to continue on that theme, you mentioned medication errors, and this is an important topic. I think if you were a pharmacist or a doctor or anything, that can be a catastrophic thing, a medication error. And really, just for our listeners and viewers who may be a bit tentative about going into pharmacy, thinking, what if I make an error? Is that the end of me? I mean, can you give some advice as to how you as a pharmacist actually negotiate trying to avoid error, and really if they have any apprehension regarding the concept of making errors in terms of medication dosages?
Yeah, no, certainly. I guess, wherever you are working, whether you're working as a pharmacist, as a nurse, as a doctor, I guess even, if you're looking above and beyond the healthcare setting, there is potential to make errors with whichever job you do. But, when it does come to pharmacy specifically, usually, most pharmacies will have something called standard operating procedures. And I guess, you could call these a bit like protocols or a step-by-step instructions as to how you would go about delivering some of the core services, such as, supply of medication. So usually these operating procedures do have safeguards built in within there to reduce the risk of errors. I think a similar principle would apply if and when you are working even within other industries like the aviation industry, where you have an error in the aviation industry. You're actually leaving your life to this pilot who's taking you on your journey, but they do tend to run through things like pre-flight checks, etc. So in a similar way, we have our protocols in place to minimize the risk of errors. And if there are any errors, which usually we tend to pick up by the time it gets to the pharmacist. So if there are any errors from the prescriber side, the role of a pharmacist in a community pharmacy, and even in a hospital pharmacy, usually if we're supplying medicines, then our job is usually to check the medicines to see whether there are things like interactions and dosage errors as well. But like I said, there are safeguards in place. It's inevitable that, you are likely to make an error, but it's not something that's very common, and it's not something that happens day in, day out. I think, it is something that we do, plan for, really.
Colin, I'm going to try and bring you in here a little bit. Is the way the pharmacists as well as the private sector to interact with patients, let's say, for example, if they need some help, do they have to go down is there scope for e-commerce or online pharmacy that institutions in the private sector could consider? I guess it's about continuity of care, isn't it? At the same time, reaching out to the person as quickly as possible. I don't know if that's something that you have.
Yeah. I mean, there are sort of private pharmacies around, but as far as a private pharmacy job role that I do within substance misuse, there are guidance that we can do from an addiction perspective. But like you say, it's continuity of care regards to having all the accurate records to that one patient. So, I mean, in the community and online issues, as long as you get all the information that the pharmacist would ask in the community, you'd ask exactly the same information if they came in on a private sector as well. So it is, the safeguarding aspects will be exactly the same. We still have SOPs, we still have to dispense medication, we have second checkers to make sure that we get the correct medication to the correct person, and it is all regulated in the same way as the NHS type community pharmacies would be as well.
The other thing is about stockpiling. We haven't heard the word Brexit being mentioned for a long time. At least it feels as though it's the whole of 2020 has not been about Brexit. But that round the corner, there's some guidance around, making sure you've got adequate supplies up to 6 weeks, if not more. I don't know what your thoughts are. Is that feasible, or are there other questions that need answering?
I guess, there were situations where there were actually true shortages of certain medicines when we were looking at Brexit. Obviously, it was a massive issue last year. It's still to come. But with COVID, it's kind of taken the back burner. But stockpiling medicines is something that can in itself cause short-term disruption with the supply chain. And I guess it was like that when we saw the situation with the toilet rolls earlier this year, where we were actually producing enough, but the acute increase in demand due to stockpiling did mean that manufacturers weren't expecting this, which ultimately affected the supply chain. And to be fair, pharmacy teams in all settings have and always will be important during medicines shortages, since as well as being integral in making medicines available to patients, we are also, I guess, trained and experienced in providing advice on alternative medicines for conditions to both patients and other healthcare professionals. I guess particularly on areas like, equivalent doses of alternative drugs. I mean, I'm sure Fahim and Mehran, both of you as registered doctors, you both, will have made use of your pharmacy colleagues for advice in this area in the past, where if there is something out of stock, we can advise on alternatives. But one thing that I can say for certain is that whatever happens in the coming months, we know that pharmacists will be working hard to put patients first and help ensure that they receive the best possible care. We also know that they could be faced with, I guess, difficult conversations with patients who are concerned about their medicines. But the key thing is, we're trying to avoid stockpiling, because that in itself can cause acute issues. And to be fair, it's only the odd few medicines, back when Brexit was a bigger issue, I guess, last year, that were in a massive acute demand, where there was a slight shortage. But right now, I think we're absolutely fine, really. Majority of medicines and everything is back in ticking order.
And Colin, we touched on addictions. I'm trying to also bring your expertise in terms of what COVID has meant and how you've had to interact and support patients in the community. There's lots of concerns about the opiate crisis. There's also just in general, mental health has unfortunately taken a hit for understandable reasons. How have things been for you and where you work?
They've been busy, shall we say, especially in the community in Blackpool, where we have drug services. We had to go through when COVID hit and there was a lockdown. There was a lot of concern around movement of patients who could be on methadone prescriptions or other opiate substitution therapy treatments going out every day. So just for the listeners, when people are started on a medication for opiate addiction, there is a period where you will have to go to the chemist for a daily basis to have the medication safely, from a harm reduction perspective, and then as you get more stable, you can then remove the number of times you have to go to the pharmacy. Unfortunately, COVID took that out of our hands, so we had to very quickly assess 800 patients over the space of about 2 weeks to ensure that they were keeping the public safe from a perspective of the lockdown, but also looking at the safeguarding issues that are directly relatable to that patient. So as a service, there was pressure nationally to swap everyone to as least pickup as possible. That may be someone going from a daily pickup all the way to a 2-weekly pickup. And I think in some chemists in Scotland, they were looking at a monthly pickup. And in our service particularly, we had concerns about risk of diversion, risk of people who are on a daily pickup for a reason, then having lots of the medication at home, and then there's several safeguarding issues concerned with that. So we risk assessed every patient, and we did it on a graded perspective. So people who were already on a weekly or twice weekly pickup, then we could move them safely to a longer pickup. But then the most chaotic patients were still kept on daily. Unfortunately, within pharmacy, because of the nature of COVID, we have a supervision perspective where some of our most at-risk clients actually have to go into the pharmacy and be witnessed taking their medication for the safety of themselves and also for others. But this quickly got removed from us when it was locked down because of They didn't have the space. They weren't able to do it safely. And the risk to the general public of COVID was greater than the risk of the supervision. So that changed very quickly overnight. And it's ran through the whole services, because we've been using supervision for decades to keep patients safe. So there were some very hard and difficult decisions to make. As it happens, we are 6 months down the line now, and our clients have become stabler. The majority of clients have actually become, because they don't have to go to the chemist every day, they have able to get on with their lives. They're able to move away from certain people that they meet who may be giving them drugs, and it has had a really positive effect for the majority. So I think it's going to turn our service nationally on its head, and will happily bring us some reviews that will give some really positives from such a really difficult situation. We've also had to increase and change our ways of how we review new patients. So whether that be people who are addicted to illicit painkillers, or illicit drugs, or prescribed painkillers that have been stopped, we've had to streamline our Zoom, our telephone consultations, and get patients in a lot quicker. And again, it's removed a lot of red tape, and we've managed to stabilize patients and get them into treatment, which is what matters, and actually support them. My biggest worry, I suppose, is for COVID is possibly alcohol. And we can touch on that if you'd like, around the unknown risks that COVID might bring with alcohol.
Yeah, no, absolutely, because there's quite a bit of evidence that alcohol consumption has increased. Even people that don't actually typically rely on alcohol, their consumption's increased. So obviously that raises vulnerabilities as well as other risks, doesn't it?
Yeah, definitely. And it's not through anyone's fault, and it's not through anyone's sort of idea that they've done it on purpose. It's the fact that time, boredom, being stuck in somewhere. COVID has brought a lot of people's anxieties to the forefront, and unfortunately, self-medication, where you can't see your friends, you can't get out to your family, understandably, alcohol does have that effect. But unfortunately, if you drink regularly, alcohol has this ability to change how your brain works. So it can make anyone physically and psychologically addicted to it. And if you haven't got a pattern of work, people may start noticing that they were having a bottle of wine of a weekend. Now it went to Friday, Saturday, then it was a drink during the day. And we just want them to know that there are services like ours out there that can offer support for that. You have local community services, your GP, because you may not know you have a physical dependence until you stop drinking, or until you try and get back into work. So furlough stops in October, you may be due to go back into work, you're starting to think about getting into a routine, and all of a sudden you don't know why you feel anxious, you don't know why you're sweating, you don't know why you feel sick, you don't know why you're not sleeping, so you might buy some sleeping tablets over the counter. And there's a lot of things to think about, and it may be inadvertently due to the extra pint you may have had in the sunshine when you were sat there, or whatever. So there's a lot of assistance out there for that.
Okay. And Atif, what have you found as an academic GP, just changing things slightly, in terms of the idea of compliance and concordance with medications is a big issue for the healthcare profession, and working in partnership with patients. From an academic angle, what sort of techniques work in asking patients to take their medications? Because it's all well and good prescribing something, but it's zero value if you don't actually take it and in the right way. Is there any things that you found that are probably helpful in getting people to ingest or actually take their medications as prescribed?
Yeah, no, certainly. It is an issue, in certain areas. And I guess one thing that we as pharmacists are quite lucky to have is patients usually really tend to open up to us. they see us as friendly people. Usually within the community pharmacy, they're able to come in without an appointment. So that I think that accessibility in itself does break a lot of barriers. But I've personally been involved in doing medication reviews in both community pharmacies and GP practices. And as you will be aware, there is, limitations as to what records we do have available within a community pharmacy setting. So, the way we've been conducting, medication reviews in community pharmacies is very different to those in GP practices. But I must say that they are really valuable in providing holistic and personalized care, since the amount of valuable points both patients and pharmacists pick up, real time and real life issues of medicines can be life changing. And I think the key thing is putting yourselves in the patient's shoes really, and empathizing with the patient themselves, because as prescribers, we have our own agenda, we have our own ideas as to what the patients should and shouldn't be doing. What you've got to remember is that patients who are taking medicines, that comes with a package and a whole host of other things. If they have got problems with things like dexterity or caring issues, or problem, reading labels, things like, things that we won't even really give much consideration to, things like swallowing issues, side effects, and sometimes even just generally forgetting to take their medicines. So I think having that open conversation, usually, saying to the patient that I'm here to help, and regardless of what the outcome is or what your concerns are, there's always a solution, and I think that really does help. So that's what I've found useful, and I guess most of the academics usually do tend to say that having that patient-centered care is key to any medication review.
Excellent. And as part of that medication review, Atif, I know you're an academic-minded, obviously, pharmacist. Many patients may actually go towards complementary medicines, herbal medication, as well as the generalized prescribed medication or over-the-counter. And how do you maintain that respect for the patient with their choices? And does it actually cause a hindrance, or is it helpful that they are able to actually turn to other things like Chinese medicine and other things, for instance?
Now, when it comes to alternative therapy, we always highly value patients' beliefs. And if patients believe that there are certain medications out there when it comes to alternative therapy that may or may not be useful, then we welcome that discussion. But one thing that I will say for certain is that there are, unfortunately, a lot of alternative therapies out there, whether they are natural or not. They can, really dangerously interact with other medicines that the patients might be taking. So, like I say, we try to have that open approach whereby if patients are adamant there will be, or there is an alternative medicine out there that they are willing to take for a particular condition, pharmacy teams, in all sectors, I guess, even in hospital as well, we are very keen to explore that as an idea. I remember when I did my training, in fact, I was working at Rotherham Hospital as a pre-registration pharmacist, and we once had this gentleman who brought in some herbal tea. Now, this herbal tea he purchased off the internet to allow him to lose some weight, and he just wanted some further information. Now, hospital pharmacies, some of them do have regional medicines information centers. All hospital pharmacies will have a medicines information center, but some of them provide this wider service to the rest of the region. And part of my role on a particular rotation was to research that drug and that herbal tea. And upon looking into this, I realized that it contained a banned substance. So sibutramine was what it contained. Now, I've not been qualified long enough to know about sibutramine when it was available on prescription, but when I did look into it, it was an agent, it was a drug that can definitely make you lose weight. So you will see the results, but the longer term effect is that it can cause cancer. So that was one of the key side effects, and it can also impact the heart as well. So I would say be really careful, and if you do come across an alternative medicine, pharmacy teams are there for you, whether it's in hospital, community, general practice. We've got the time, we've got the resources, we've got the expertise to look into these complementary medicines and advise you further, really.
Okay. No, that's great, Atif. I guess it was a philosophical issue. If I bring it back to Colin as well, in terms of just a philosophical point, slightly different tack, but again, the philosophy of addiction. Some people don't believe that's an actual thing out there, Colin, and it's in the media and things. Can you try and help engage and actually educate the listeners and the viewers as to why they should take addiction on as a serious thing that affects people, and not just a case of willpower or it not existing?
Yeah, of course. I mean, addiction, if everyone reflected on what they thought about addiction meant, it would be different for everyone. Most people, if you say addiction, they think of the person with the needle in their arm who is using high amounts of class A drugs, who's stealing to get their drugs, who's doing this, who lives on their own, who lives in a hovel or whatever. Whereas addiction is just something that everyone, if they reflect on what they think about it, actually goes through. So you could be addicted to drugs, you could be addicted to chocolate, you could be addicted to shoes, to shopping. Addiction is just a way that the brain stimulates your pleasure centers to actually give you something that you feel like you're missing. So it's not so much the product that you're addicted to or whatever it is, it's the reason why people are doing things that potentially cause addiction. Anyone can have addiction, but therefore no one chooses to be an addict in its purest sense. So if you look at the definition of addiction, you are doing something that you know is harmful to yourself, but you continue doing it. There's a level of tolerance, therefore you have to do more than what you did last time to get the same effect. You then have dependence. You also have an element of withdrawal where you feel worse if you don't do it. No one would ever choose to have those negative feelings, and it's about reflecting on no judgment for someone who's in that position, because the reason why people do things are a lot different, and what we need to do as a society is understand that someone who's addicted to a substance won't choose to be at that point. What's happened to them in their lives up until that point has made them make those choices, and you're judging someone from a society perspective that if you had done exactly the same thing as them, you would be making the same choices as them. Unfortunately, we do judge, and we judge people from our own values. And if someone's never been taught about a value, or taught that something's wrong, or taught that something's right, then they can't have the same choice. So having judgment of empathy in people will then make you understand that addiction is not necessarily a choice. So there is the argument around there are genetic factors of addictions for alcoholism. Addiction does show from brain scans and evidence that the area that affects the pleasure centers of the brain that affects you to be likely to be addicted to a substance are stimulated in people who are likely to have those addictive traits. The addictive personality conversation is you could spend a whole hour talking about that as well. But I think it's for people to reflect on the stigma attached to the word addict. In their greatest, we deal with our patients who are the most stigmatized. They're the most vulnerable. They've been through the worst things in their lives generally to be where they are now. And if you don't support, then no one's going to come out of there. And you support with judgment and empathy. And just remember, addiction isn't the substance. It's the pathway that continues to doing what is destructive. So it's doing the same thing and expecting a different outcome, which is obviously the definition of insanity. But we all do it. So, yeah, I think if we want to do anything, we need to understand why people do something, not stigmatize them because it's an illegal drug, therefore you're bad. So why is it you've got to that point?
Yeah, just to add to that, Colin, just obviously from a psychiatrist perspective, you do commonly see that people who unfortunately find themselves in that situation are either misunderstood, miscategorized, or ostracized from community. So it's because these individuals that probably need a bit more time to actually try to get to the bottom of it. So if they want to feel better, is it because they feel stressed? Do they want to feel good? Is that because they feel down? And what seems to be fueling that behavior? And obviously it's about the wiring in the brain that leads to them to adopt certain behaviors and compulsions, and over time those demands increase. Hence, the tolerance starts to change. So that it's a very much a vicious cycle. But there are therapeutic approaches, aren't there? There is cognitive behavior therapy. There's obviously counseling. There's interpersonal therapy. So there are strategies to try and help those individuals.
Definitely. And I think the biggest help we can give to individuals is to get them to understand why they keep doing the same behavior, because they won't know. It's normal to do something subconsciously that we've learned from the ages of 1 to 7 without knowing that we actually do it. And you'll just continue doing it. And generally, if someone looks at your belief as being wrong, you will challenge that aggressively, and because you are trying to prove that it's right. And if someone else proves you're wrong, and it's usually built in with deep insecurities of people not thinking that they're good enough, or I'm not happy enough, or if I was, everyone loved me and I was a friend, I would be happy, or if I had this car or I'd have this money, then that's the same as taking the drug. So one day when I take this drug, my anxiety will go, but it won't, because once the drug stops, your anxiety will come back. So you take more drug, or you buy more shoes, or you eat more chocolate, or you watch more films, or whatever that addiction is the something to replace what is negatively inside you, which you don't know about. So it's like building a house on no foundations. Doesn't matter how big the house is, if the foundations are poor, they'll fall over. And you need to ask that question of why, and be aware of your fears, and look at, and talking therapies are most definitely the way to go. Antidepressants are prescribed a lot and are probably not as successful in treatment as what talking therapies could be. But it takes time to find out why you've been doing something for 30 years or 40 years, and to actually then have tools. Once you're aware of why you do something, you can then look at it. But if you don't know why you do something, you can't change it, can you?
Because there is increased focus for things such as cocodamol or Nurofen Plus to be actually prescription only. Because I guess we don't want to follow certain countries across the pond in terms of the opiate crisis, because we have to understand that prescribers are also part of the problem. That's what happened in America, and it was I guess everything is easier on hindsight. Is this what we're trying to address in the UK?
I think we are trying to address it, and I agree our prescribing of opiates is too high, especially for chronic pain. We know it only works in about 1 in 10 people for chronic pain. For acute pain, yes, if I went in with a broken leg or been in a car accident, most definitely I know what drugs I would be asking for, because I know how well they work on acute pain. For chronic pain, we need to concentrate more on the fact that it's physiotherapy, it's rehabilitation. Drugs don't work long term, and you keep getting further up. And this may be controversial, but I don't think moving everything to prescription is going to stop people needing those medications, because society doesn't give them any other option. So funding is cut. The reason why mental health services, a lot of pain can come from anxiety, and it's not actually pain of the body, it's pain of the mind, and they don't get the treatment to do it. So codeine is going to stop pain. Opiates numb your mood. They're an emotional blunting tool. There was a reason Hitler used methadone for his soldiers. So it was to numb the emotion, to numb the pain, to go off fighting, and all that will do will push GPs. Will have a queue going out of their door, and they've got 10 minutes, and it's very, very difficult to have a conversation as to, I'm not giving you this because it's not evidence-based and it doesn't work. But for someone who's took it for more than 4 to 8 weeks, who feel sick when they don't have it, it's very emotive. And the first services generally to get cut are addiction services, and that takes us back to how emotive the word addict is, and people's society's perception of addiction. Oh well, I wouldn't bother treating them, or the stigma that's attached. Whereas, look, the schools are shutting, or the hospitals are shutting, and it is a bigger picture, because everyone at some point in their family will have someone that addiction is affecting. 100%. Whether they admit it or not is a different matter, or whether they know that addiction. And that doesn't mean it is heroin or it is really heavy drugs. It could be as much as the mental health of self-soothing with self-harm, or insulin overuse, or there's loads of different types of addiction but aren't categorized as addiction. And I think changing society's outlook on reducing the stigma is the most important thing, and just stopping everyone being so angry and judgmental about everyone, because you have no idea why people get where they are until you speak to them. And once you speak to them, you understand that actually, I can understand why you're using drugs, because if I had that life, I would want to use drugs. So you have no home, you have no friends, you have no anything that people want. All they had were drugs and no one there. And then as soon as you use drugs, you become an addict and you get stigmatized, and it's a vicious circle. So there's some really great work going out there from a lot of services. We just need to have a louder voice, definitely.
And Atif, obviously, I was reading the news today, and the government came out with restrictions on laxatives that are coming out in terms, I think it's to do with, obviously, maybe bulimia or eating disorders. And so they're trying to reduce that. Can you give the maybe listeners and the viewers some ideas, an academic pharmacist, how people make these decisions with the MHRA? They might have heard of FDA and all of these things. How is it all regulated, the medication that comes out onto the market, and why is it different, say, in Europe to USA, and the different rules and regulations? Because you can get many things on the internet, other things are regulated. You can go to the continent, get a different packet, maybe a salbutamol inhaler very easily. If you go to some parts of Asia, you can get antibiotics at the counter, so what's the deal with all of this, Atif?
That's a very long question as well.
It is a very long question, I guess. But basically, just to keep it, I guess, short, sweet, and simple, usually medicines tend to have a process, under which they are given a license. So usually within the UK, we follow a lot of the legislation within the EU, whereby clinical trials take place. But as you can understand, these clinical trials only take place in usually healthy, healthy male patients and populations. And then, in order to find out how medicines are reacting in the wider population, there needs to be post-market surveillance. So once a medicine reaches once a medicine reaches the guidelines and it is being prescribed, only then do we really know what kind of side effects it's likely to cause in things like women and elderly patients and children. So the recent news that you have highlighted with regards to the laxatives, there have been extensive post-marketing surveillance trials that have shown that these medicines can cause real problem if they are misused. But yeah, the reason why you will have different regulations with different countries it depends on, I guess, the laws. It also depends on legislations that have been put in place. Online, you do see, unfortunately, a lot of fake medicines as well. So if and when patients are choosing to purchase anything online, then they should make sure that they are accessing a reputable online pharmacy. So you can get this information from the NHS website. So if you were to go onto the NHS website, it tells you which pharmacies are registered, and I would encourage patients to do that.
Excellent. We've rapidly coming to the end of our time. It's our normal custom to ask people for their 3 top tips before they leave. And in time-honored tradition, could I come to you, Colin, first? Obviously, there's been a very informative, educating process that's gone on over the last hour. What things would you like to leave the listeners so they can actually understand and take something away from this program?
I would probably say don't judge people without knowing the answers of why they are where they are. Addiction can affect everyone, and there are services out there like ourselves with COVID to look at the alcohol and risk of dependence that you may get. So speak to us if you have concerns.
Excellent. And Atif, any tips to either the upcoming students or general public regarding pharmacy that you want to leave us with?
Yeah, I guess with the upcoming students and the wider public is that pharmacy as a profession is a lot more diverse than people think of it as or are aware of. So, it is a very exciting career opportunity, and, I've never looked back. So I would definitely encourage future students to have a look into pharmacy. As far as patients are concerned, I would say, use your community pharmacy, local pharmacies. There is a lot of good work that they are doing, and, they do value patient care. And I guess the last thing that I would like to say is, I know there's been, a lot of remote consultations through GP practices as well. Just remember, your GP practices and pharmacies are still open through COVID. So if you do have any problems, don't stay quiet and make sure you approach them, because you can still be seen. If there is a problem, we will address this.
Great. Go on, Fahim, you're about to say something.
No, I just think I wanted to thank both of our guests. We have come to the end of our time. I know we talked about some serious issues today, on top of obviously pharmacy. So if anyone's affected who's watched today's program or been listening and may have a drug addiction or know someone with a drug addiction, it's important, as the NHS UK website says, that you're entitled to NHS care in the same way as anyone else who has a health problem. GP is a good place to start. The Talk to Frank website as well, so talktofrank.com, and also the Frank Drugs helpline on 0300 123 6600, 0300 123 6600, if you or anyone you love is affected by the issues that we've covered tonight. Over to you, Mehran, to close the program.
Yeah, so obviously great to have both of you on. We're getting some feedback. So this is what Claire Ilias said. Just listening to you guys, great promotion pharmacy roles. Also, highlighted Colin specifically. But it's great to have you both on board. I think everyone is going through changes in terms of how they operate. I think pharmacy and pharmaceutical companies are looking at that as well in terms of how they need to evolve, because otherwise they'll be left behind. So I think there's certainly opportunities being given that way. So thank you again. I think next week we've got Slater and Gordon lawyers, so we're going to be discussing medical negligence. So if you've been in been in receipt of an injury or other issues, certainly that's one to listen and watch. So keep those questions coming in. So I just want to thank again. Hope to see you all next Tuesday from 8 to 9.
Thank you so much, and good evening.
Thank you.